Dr. Marwan Moussa is an instructor at Harvard Medical School. He's also the co-director of Minimally Invasive Tumor Therapy Lab and Endocrine Interventions Service Line at BIDMC. He did his medical school at Alexandria University Faculty of Medicine, residency at Arkansas, and fellowship at BIDMC. This is a relatively new field, and so we're very excited to have him speak with us about that today.
Excellent. All righty. Well, thank you for giving me the opportunity to talk about a topic that is near and dear to my heart, which is immunotherapy and personalized medicine in IR. And for the interest of time, I've really summarized this into two categories: important milestones and limitations of IO or immuno-oncology, as well as how can we combine interventional oncology, IO, with immuno-oncology, IO squared or IO 2.0, depending on who coined it first. But so what are the important immunotherapy milestones that one needs to familiarize themselves with? I think the first one is Cooley. Cooley's toxin, I think, holds a very important lesson to us, especially students coming into this field. Um, Immunotherapy started when Dr. Cooley met Beth, a 17-year-old with sarcoma whom he amputated her leg. Then she died, shortly thereafter died. He was so uh, devastated by the fact that he went into his own institution's records and tried to see other patients with similar conditions. How did they fare? And he found the record of Stein, a German immigrant who came years before that, had a similar sarcoma, soft tumor tissue, but he also developed a fever, and that tumor shrunk, and that Stein left the hospital. Cooley tracked this gentleman in the back streets of New York and found him 7 years later alive, and understood that we can induce something that can kill tumors. So the take-home message here is that remember your patients, learn from your patients, be curious, and you will fall onto holy grails, as is immunotherapy. So his work was unnoticed for 50 years, then until about 1983, 1985, when adoptive cell therapy was starting to come about, where autologous cells were expanded and then infused in patients. And as you can see here in this chest X-ray, marked by the right, multi metastatic disease in both lungs. And then after autologous cell therapy, the lesions are gone, and the patient, 50% of them had a complete response. Then comes the Nobel laureate and winner, Dr. Ellison, to describe the effects of immune checkpoint blockade in tumor control and cancer. And since then, there's been an explosive growth in immunotherapy. As you can see, from 2017 to 2020, doubling of agents and the targets that we've identified. However, there are limitations to immuno-oncology, and the main one is you have a very low patient population that responds. So you have patients who are called primary resistors, and then you have secondary resistors. After they have initial response, then they develop a secondary response. What we're trying to achieve is that tail end of it all, the durable response in patients, where they live years and years having a durable anti-tumor response. But that is a very low number of patients. In addition to that, these agents will have multiple toxicities. You will have limitations in how we can deliver them to tumors. And as you can see here, the very high number of non-responders, and that is particular to immune checkpoint inhibitors. However, these are the flagships of immunotherapy in this day and age. So can we combine interventional oncology, IO, with immuno-oncology? Excuse me for the typo. And the answer is yes. By converting what are cold tumors or cold tumor microenvironments into hot ones. Uh, Whether it's ablation or embolization, that results in a release of antigens, inflammatory cytokines, and signals that allow for trafficking of immune cells and proliferation and activation of immune cells, as demonstrated by these images here, particularly antigen-presenting cells such as dendritic cells and T lymphocytes, the main executive cells when it comes to T cell specific anti-tumor immunity. So this is an example of how interventional oncology, or in this case, ablation, cryoablation, can result in an abscopal effect. This is a patient who has a metastatic RCC to the lung that is growing. And as Dr. Su was saying, this is one of those patients where you see, is this oligometastatic? Is this a patient who can benefit from ablation? But also he had growth in the tumor bed of the RCC resection. So the patient undergoes ablation, as you can see here in image D, and 3 months later, the lung lesion has started to decrease in size, and then 9 months down the road, that lesion's almost non-existent. So we do see this happen. However, this is very rare, which is ablation-induced abscopal effect. We do know, we have some idea why this happens. So for instance, this is a study that showed people or patients after cryoablation, and you can see here that there is dendritic cell and T cell proliferation. Specifically, you can see CD8s, CD4s. You can see that the CD8 FOXP3, which is the Tregs versus the cytotoxic lymphocytes ratio, airing onto the side or favoring the side of the CTLs, the cytotoxic lymphocytes. You can see granzyme B and A up, which are some of the effector markers of cytotoxic lymphocyte activity. So we know that ablation induces this, but why is it sporadic? How can we maintain it is the question that, or the holy grail in IR that everyone's trying to get to. We also understand that every ablation modality offers something differently. This is a very elegantly designed experiment where melanoma cells were exposed to um, thermal ablation, cryoablation, and IRE. And as you can see here from the graphs, each ablation kind of takes leadership in one part. So for instance, here in protein release, IRE was beyond was the leader, while as far as the native protein, the protein that is specific to the tumor antigens, cryo and IRE were similar. However, denaturing protein was more for the hot or thermal ablation. However, when it comes to T cell activation, you can see that IRE was the leader. So can we combine immuno-oncology with IO? The answer is yes. Is it in current clinical practice? No. However, this is an example of combining them and the outcome. So this is a patient with a non-small cell lung cancer, where you can see that they are here have metastasis or recurrence, I apologize. And they underwent immunotherapy with initial response, then developed a secondary resistance, underwent ablation, was off immunotherapy, and had a complete response. Again, this is rare, but it does happen, and we're trying to understand why. So this is one of the reasons why we think this happens is when you combine ablation, in this case cryoablation, with an immune checkpoint inhibitor, you can see that distant tumors, this is a fluorescent image of a tumor distant from that was treated, and you can see the infiltration of CD4 and CD8, those that are blue and green cells, and CD31, which is microvascular density. So that has a positive effect on the tumor microenvironment, making it more hot. This is another example of combining cryoablation with ACT. And you can see here that, again, the number of metastases in the cryotherapy arm was the least in comparison to surgery. This is another model of prostate cancer in mice where ablation was combined with immune checkpoint inhibitors. And you can see again that nice tail of free survival of the combination group extending beyond all other treatment arms. And this is something that we are currently doing in our lab where we're trying to ablate a tumor in the liver of the mouse and inject another foci of microscopic disease in a remote part of the liver, ablate the dominant tumor, inject an immunostimulant so that the T cells infiltrate the ablated area, and then inject an immune checkpoint inhibitor to allow these primed cytotoxic lymphocytes to be released, kind of like a priming and release, so that these microscopic foci are destroyed. Currently, there's more than 41 trials ongoing combining cryoablation and other modalities with other agents of immunotherapy in multiple types of primary tumors. And this is one of the results where radiofrequency ablation was combined with immune checkpoint inhibitors. And you can see that between partial responses and stable responses, the majority of patients demonstrated that, while the lower number of patients demonstrated progressive disease. And again, driving the point that combination does have a room in our clinical practice, but yet still requires to understand what modality to be combined with which immunotherapy at what time point. Take home points. Remember your patients, learn from them, be curious. Remember that this started with Bessie and Stein. Remember that immunotherapeutic agents are very powerful tools, however, are limited into the number of patients that they can affect. And we have a role in expanding that to the larger populace of patients. And remember, again, stay curious, look and see your patients, follow them up, like this patient here who had a foci of metastasis in the lung, had ablation distantly, and then had abscopal effect. And I leave that here. These are my references, and I just thought I'd leave the rest of the time for questions.
Thank you so much, Dr. Moussa. Oh, amazing presentation. So exciting. I think we have time for one question. Start, Nathan.
Yeah, so we have one question in the chat. Do you foresee a future where targeted delivery of immunoactive agents could be beneficial?
I think that is that's low-hanging fruit, and I think that definitely can. So, for instance, this slide that I just demonstrated is actually a part of that. We know when combining nanotherapy with ablation, that nanotherapy travels to the tumor bed and therefore increases drug delivery. So, if you identify oligoprogressive foci, certainly can be ablated or just intraarterial embolization with immunotherapies. So that is something definitely low-hanging fruit that we should be after and will identify throughout the coming years.
Thank you, Dr. Moussa.
Pleasure to meet you, Torrin.
As well.